So we are live.
A very good evening to one and all from team HPOS. As we all know, these are difficult times due to the COVID pandemic, but we shall continue to learn. The topic for today's webinar is Basics of Glaucoma. Glaucoma is one of the leading causes of irreversible blindness, which poses challenge to all the treating ophthalmologists. Myself, Dr. S.K. Soni, President HPOS, to introduce Dr. Sushmita Kaushik, eminent professor glaucoma, PGI Chandigarh. She is a renowned glaucoma specialist and has numerous publications in national and international journals to her credit. We are privileged to have Dr. Sushmita as guest speaker for today. Every one of us will be enlightened by her vast experience in the field of glaucoma. Among panelists, we are lucky to have Dr. Ramlal Sharma, Professor and Head, Department of Ophthalmology, IGMC Shimla, Dr. Rajiv Tulli, Professor and Head, Department of Ophthalmology, Dr. R.K. GMC Tanda, and Dr. Vinod Sharma, Associate Professor, Department of Ophthalmology, IGMC Shimla, who is looking after glaucoma specialty. We would love to have interactive and informative session. This is the first webinar and we will try to organize more in future. Over to Dr. Ramlal.
Thank you very much, sir, for nice introduction. I welcome you all on behalf of HPOS, as Dr. Soni, our President HPOS, has already welcomed you all. I do have a special welcome for Dr. Sushmita, who had specially been part of this webinar on glaucoma from PGI Chandigarh. She has already been introduced by our President, Dr. Soni. As far as her personality is concerned, which I'll be talking to you, is that she is very, very energetic and always cheerful in her work, because we had worked together at GMC Chandigarh for at least 1.5 years in around 2000. And following that, she joined at PGI Chandigarh, where she has done lots of work and has lots of presentation and publication to her credit at national and international level. So we are lucky to have her here and to give a stimulus to this webinar. As we have not been able to do a conference this year, so we thought it to have some kind of interactive session, as Dr. Soni has already told that this is a difficult time, really very, very difficult time. Particularly Shimla or Himachal Pradesh is recording one of the highest cases these days. So throughout the day, we keep on struggling with these tracing and tracking of all the cases and our staff, which is going positive day and night every day. But still, let's have some refreshing this knowledgeable or a review session on glaucoma, which I have specially requested, which will be useful for our ophthalmologist of the state. I am also thankful to Introd International, Introd Pharmaceutical, who has really organized or have basically taken part in meeting us all together. Before Dr. Sushmita come, let's have some sponsored part of their this phenocane assisted cataract surgery, which is one of an excellent drug that they have introduced into the market, where both anesthesia as well as the dilatation of the pupil can be carried out during, particularly when topical cataract surgery or the topical phaco is being done. So with this welcome, I move on further. Something about this sponsored session. I do not have any financial interest. It is just a sponsored presentation from them, which I'll be just reading through. Cataract surgery, as you know, with intraocular implantation requires mydriasis. We all are aware. And a survey or a stable mydriasis is rated as one of the most important determinant, as we all know. If the pupil goes down, surgery is always difficult, or it is invariably sometimes the complicated one. So rapid mydriasis particularly is one of the very, very important factor whenever we go for the cataract surgery, particularly whenever the intraoperative meiosis occur even during surgery. Despite numerous advances in cataract surgery, mydriasis is one of the foremost concern of the cataract surgeon. As soon as you see a constricted pupil during surgery, you immediately start looking around that why this pupil is meiotic. So you always tend to go in a stressful situation. So a complication of intraoperatic meiosis, as we all know, cataract surgery can jeopardize the IOL implantation. It can cause complication, including iris trauma and posterior rupture with the vitreous loss. We all know intraoperative complication. The surgery is prolonged invariably, increasing the risk factor for endophthalmitis, macular edema, and of course, iris trauma, particularly phaco. During phaco, this is very, very important factor. If pupil goes slightly even by 2 millimeters down, the chances of getting the iris into the phaco probe is invariably there. So complication rate is increased. So the stable mydriasis, it facilitates the surgical maneuvers such as cortical cleaning, capsular access, IOL implantation, and accurate positioning of the toric IOL. This is another important thing that recently we are seeing lots of surgeons are doing toric IOLs. So the position, accurate position of the axis is very important. If it's not visible, particularly when the pupil is constricted, then it really becomes difficult. And even slightest change, as you know, in the axis will really spoil the surgery, particularly for the toric IOL. Intraoperative complication, as we have told, one of this survey on cataract surgery, that stable mydriasis is one of the important factor that is rated on the scale of 9. Even if you have all other situation, difficult situation, but mydriasis is one of the very, very important determinant of the cataract surgery outcome. So the pupillary dilatation, very, very important. So topical mydriasis definitely is an advantageous delayed onset of mydriasis. That is what we do whenever we put drops. There is a limited viability. Invariably, patient closes his eye. Lots of factors are there. Drops are not properly put simultaneously. 2 or 3 drops. We tend to put preoperative dilatation when we do it with the drops, particularly. So it is lots of drug is wasted. The penetration of drug may not be. That's why people may not dilate many times. Multiple doses of eye drop, as we know, phenylephrine, tropicamide, anesthesia on ocular surface will always cause superficial keratopathy. This is a known phenomenon. Many times I have seen this complication that lots of drops are put just to dilate the pupil, and it invariably cause toxicity of the cornea, which might hamper your surgery during the procedure. So inconstant mydriasis and intraoperative pupillary meiosis is another important factor. So as soon as you go inside, the pupil tend to become meiotic. So non-negligible systemic absorption. Another important factor is many times, particularly the children, they develop even the psychotic type of symptom following cyclopentolate. This I had seen myself. So not only the topical, but the systemic complications are known, which possibly we can avoid the intracameral injection of mydriatics. Another important thing is many times I had seen sometime our resident, they forget to dilate the pupil. As soon as you push the drug, even without any drop being put in the patient, pupil dilate immediately. So mydriasis stays there for 4 or 5 minutes by the time you complete your surgery, or 10 minutes time. And that is sufficient time that you need if the surgery is an uncomplicated one. So safe and effective alternative with less systemic exposure and significantly less pain and sensation. It does cause lots of pain relief, particularly when the phaco probe goes in. Many patients, they tend to complain pain due to the pressure itself. So 95% of the pupil dilatation was achieved with a mean of 28-second administration of intracameral injection of this drug. The mean pupil diameter is on average 7 millimeter, which is required for surgery. Intraoperative pupil diameter remained stable in intracameral combination group and decreased in topical group, one of the study which have suggested that it works better. No clinical significant change in pupillary diameter, particularly less than 1 millimeter, occurred in majority of cases. This is one of the study they quote that it works very well during the surgically, even in undilated pupil. So mean dilatation of pupil time is this much. So this is the injection they recommend. I have also used, found very, very useful. So this was their sponsored session. With this, I thank you all. Thank you very much. Now our question part we'll take in the end. Now I invite Dr. Sushmita for the presentation. Thank you very much. Then after this presentation, we'll go for the question answer session. Dr. Sushmita, please.
I think you'll have to stop sharing because it says
okay.
I can't share. Yeah.
Stop, doctor.
Yeah, okay.
Okay, just net. I have stopped sharing, Dr. Sushmita, if you can now connect.
Okay, yeah, I don't know why. Let me see, maybe I have to switch it on first. Okay. All right. Yeah, here it is.
Yes, yeah. Yes, it's visible now.
Yeah, right. So should I go ahead and start?
Yes, yes, yes.
Yeah, okay. Right, so good evening, everybody. And at the outset, thank you very much, Dr. Sharma and HPOS, Dr. Soni and Dr. Tuli for having me on. And it's a pleasure to be part of the first webinar of the HPOS. And thank you, Entot, for making this happen. So Dr. Ramlal asked me to do an overview of glaucoma as we practice every day. So I've just put in some thoughts and thought about how we do an everyday glaucoma practice, and I hope this will be useful. So I thought we could go over how to screen, who in the population do we think would have glaucoma, what are the tools we have on hand, and what are the major management protocols. So why must we bother? Now, the problem is that an estimated 12 million people affected by glaucoma in India, and the majority, 90%, are undiagnosed. So that's the problem. And even in developed countries, it's estimated that 50% are undiagnosed. So it's quite an undetected problem. And by this year, the projection was that this was likely to be about 16 million. So how can we change the scenario of 90% of glaucomas being not even known? So the major element of glaucoma strategy is case detection. And what that is called is an opportunistic screening, which means we must use the opportunity to detect at least the obvious glaucomas. And that opportunity will come to us whenever a patient comes to us with an ophthalmological problem, because it's very, very difficult to go out into the population and screen. But what we don't want to miss are clear-cut cases with established function loss. And these are the ones that remain undiagnosed. So the only thing that is going to help us do that is a comprehensive examination of every patient, which includes slit lamp, IOP, gonioscopy, and a dilated disc examination. And why it happens, and I'd like to quote Professor Ravi Thomas from his landmark paper of glaucoma in India, where he looked at the current status. And he said that the excuses for incomplete examination were frequently a poor developing country grown, and a cost of slit lamp, applanation tonometers, and diagnostic lenses known. And he went on to say, and he's often said that, and we echo his sentiments, that if you have money to buy a phaco machine and a microscope and the electricity to run it, then you jolly well have the money to buy a slit lamp, a gonioscope, and an applanation tonometer, and have the money to run it as well. So what do we have? After all, at the end of the day, we need to look at the intraocular pressures. We need to look at the optic nerve head. We need to look at the angles. And then once we think that we're dealing with glaucoma, we need to have a visual field evaluation to know how much is the functional loss. So the current practice is to use the NCT for screening, though it's less reliable. It may be prudent to check for any high IOP on the NCT by Goldman. So NCT is known to be in agreement at when the pressures are less than 21. Any pressure more than 21, maybe that can be a caveat, has to be checked on Goldman. But the main thing is, do not diagnose or manage any glaucomas on an NCT. So the NCT should be, the message should be, it's a screening tool for when people come in, a quick way to know that it's not that you're not going to miss glaucomas even then, but then at least the obvious ones may not be missed. The next is a gonioscopy. Why is it important? Because Asians will represent 87% of those with angle closure glaucoma by 2020. And 91% of people who are bilaterally blind from glaucoma have angle closure glaucoma. So that's why it's important, because this glaucoma is the blinding glaucoma. The JOAGs and POAGs may not make them blind as much as the angle closures will. So to just go through Foster's classification, an occludable angle is one in which the posterior part of the trabecular meshwork is visible in less than 90 degrees of the angle. And it's not time consuming and patients are cooperative. This is one of my favorite slides of a 3-year-old girl allowing me to gonioscope her. So if you have them in your confidence and take a little bit more time, the gonioscopy is very much possible. The next is the optic nerve assessment. Of course, we need to examine, or you can assess disc photographs. Now, the problems are that you require pupillary dilatation. There's considerable inter-observer variation, and it's highly observer dependent as well. But at least it separates out the obvious glaucomas from the normal. Surely we can make out a more than 0.7 cup to disc ratio and at least sift out that. And that is what, it's not that less than 0.7 will not have glaucomas, but it's unlikely that somebody with more than 0.7 will not have glaucoma. So at least that is taken care of. And once we have that, there's visual field testing. The disadvantage, of course, are that it's subjective. It may not be universally applicable, and initial testing may give you spurious results. But then it's been demonstrated to be the single best discriminator between normal individuals and those with open angle glaucoma. So if there's one thing that will distinguish the two more than the IOP and the optic disc, it is a functional loss on the visual field. So to summarize, the entity that we know as glaucoma is a chronic optic neuropathy. So there is typical structural damage in the optic disc, and it is accompanied by or leading to corresponding functional changes in the visual field. So that in the nutshell is what glaucoma should be understood as. And raised intraocular pressure, we must remember, is a causal risk factor. It's the only risk factor that we can treat, but it is neither sufficient nor necessary for a diagnosis. So raised pressure is not enough, and it's neither necessary. So we must understand that it only tells us how much it needs to be lowered. So the diagnosis of glaucoma really is clinical. It requires a comprehensive eye exam, and that's all it requires. Slit lamp, stereoscopic evaluation of the disc, applanation tonometry, gonioscopy, automated perimetry if glaucoma is suspected. Imaging is not essential. You may have a role in the follow-up, but otherwise imaging is not essential for either the diagnosis or the treatment of glaucoma. So coming to who requires a diagnosis, which is the subset of people who you want to diagnose? Obviously all the glaucomas, because those are the ones who are going to eventually become blind if we don't take care of them. The problem is it's asymptomatic till the late stages, and diagnosis of end-stage glaucoma is straightforward, but the prognosis is pretty poor. It's better to detect earlier because the diagnosis is possible, and yet the intervention can alter the stage, the course of the disease and change the prognosis. So if we just look at this famous graph, this is an RGC attrition in a normal individual over time, over his lifetime. And this is what glaucoma has. Now, there's no way that this can come back here, yes, but the earlier we catch it, the more likely we treat and bring it back to this slope, the more likely it is that the patient will have vision during his entire lifetime. And obviously, the worse down the line we go, the more difficult it will be to ensure that the patient has functional vision. So why is it important to diagnose a glaucoma suspect who does not have glaucoma as yet? One is to detect the risk of glaucomatous optic nerve damage early and to lower intraocular pressures in individuals at high risk. So you can, if you diagnose them properly, maybe prevent a visual field loss before it even happens. So which are these suspects? So you've seen a glaucoma suspect, maybe a disc which is suspicious, but the fields are normal. Now, which are the ones which you should be wary of and you should take care of? Elevated intraocular pressure, of course, the ocular hypertensive is at more risk of glaucomatous damage than maybe a disc suspect without raised intraocular pressure. An older age, because glaucoma, after all, is a disease of the elderly. A family history of glaucoma. And remember, family history rather means siblings. It seems to be very, patients seem to be very cheated when you tell them that your spouse is not your family. So they need to understand that family means a blood relation, either a parent or a sibling. That is the most important. Thinner central corneas. So if you've done the pachymetry, if an ocular hypertensive have thinner corneas, they are more likely to progress to POAG. And then, of course, there are extraneous factors. Anybody who is suspicious and yet say is an asthmatic, so they'll be, you know that they're going to be on steroid use, who's had trauma, who has pseudoexfoliation, pigment dispersion, who is a myope, and who has undergone ocular surgery. So these are some of the situations, everything else being the same. These are the subset of patients who you'll be a little more careful about and say that, look, I'm not treating you today, but I need you to come back for follow-up because we're not sure about tomorrow. Now, once you have diagnosed, what's the next thing? What do you do? So the fundamental goal, as we've seen, is to slow the rate of cell loss to an age-dependent rate. There's no way that we're going to make them normal. And that's what we tell our patients is today is day 0. And we are going to take it from here. There is no way I'm going to be able to take you to day minus. So we start today, and whatever we have today, the idea is to save as much of what we have as is possible. And it's easy to explain to the residents. What I tell them is the optic disc is like a donut. So we shouldn't be interested in the hole in the center, but we need to be interested in the chocolate that remains. So we have to be interested in the rim that is remaining and try to preserve as much of that as possible. So we've already gone through the risk factors for development. Now the risk factors for development are the same as they are for progression. So elevated IOP, family history, advanced stage, race and genetic factors are additional. So if somebody has glaucoma, who is the glaucoma who is likely to progress to blindness? Again, the same set of problems. So first it was the suspect who is likely to become glaucomatous, and this is a glaucoma who is likely to progress. So these are the people who we have to be more careful about. Now, remember that lowering IOP helps all types of patients. So there's no question in saying that let's not reduce the pressure. So whether it's high tension glaucoma, whether it's normal tension, or whether it's ocular hypertension, there is evidence now, enough evidence to show that if you lower the pressure, the risk of going on and progressing is less. So then the question would be, how much do you lower? And that's where the concept comes of a target IOP. What a target IOP simply means, what is the pressure which I should target? So it's set on an individual basis after weighing the risks and benefits of treatment. It represents a range of acceptable IOPs within which the progression you think would be slowed or halted, but it has to be reviewed and adjusted because we're not God. I think that the pressure of 16 to 18 should be okay, but hey, he's still progressing at 18, so maybe it has to be 15. Or conversely, I'm giving him 5 drugs, the pressures are 18, but the fellow is miserable with drugs, but his fields are fine. So maybe even 20 will be fine for him. So you need to review that depending on what the patient has. So step 1 is assess disease severity. That's the first thing to see before deciding how much to lower. Now, these are definitions, so I've put this in. Early is a cup-disc ratio less than 0.7 with early visual field defects of less than -6 diopters. Decibels. A moderate POAG, a cup-to-disc ratio 0.7 to 0.85, no visual field defect in the central 10 degrees. And an advanced POAG is a cup-to-disc ratio of more than 0.85, which means 0.9 or more, and a visual field defect in the central 10 degrees. So these are broad definitions, and as we'll go on to see, each of these stages of glaucoma mean very different things, as to how much to lower the pressures. So when we set the target, an early would have 25% reduction, a moderate would require maybe 35%, and an advanced at about 50%. But in advanced POAGs, you want the pressures around 12, low teens, mid-teens, and high teens are all right. Ocular hypertension with no disc damage, a 20% reduction with a less than 21 is good enough. So these are broadly what we believe are standard treatment and target goals. But then, as we said, it should be individualized, and they're based upon, apart from the stage of disease, other things, the initial pressures. So if the pressures are high, our targets can be high too. So if you have a glaucomatous damage at 40, that's okay, because probably lowering it down to less than 21 should be fine. But if you've had glaucomatous damage at 21, then you're in trouble, because then you need to lower it really, really down to 10 or 12, and that is not easy. Then the stage of the disease. Intuitively, if you have a more advanced glaucoma, you need to set lower targets than if you have early glaucomas. Then life expectancy. If you have a, say, 85-year-old man with moderate glaucomas, you might think that in his lifetime, he's not going to go blind. However, prescribing medication is going to be more difficult for him. So maybe it doesn't matter if you don't treat also. So the life expectancy, on the other hand, if it's a baby, then you go whole hog, you do surgery, and you're very, very aggressive, because you know that you need to tide over the next 80 years of this individual's life. Then the rate of damage, there are slow and fast progressors, which you see as you serially follow up your patients. And the central corneal thickness, of course, thinner corneas mean the target should be lower, because probably the IOP that you've measured is fallaciously low. The idea is to maintain functional vision throughout the patient's lifetime and ensure that he has a quality of life as well. So this is a little crowded slide, but it's a nice thing to show. This is from the European Glaucoma Society. So you can see that. So where damage has occurred is most important. The higher target and the lower target depends on the IOP, on the life expectancy, and the stage of glaucoma. So if it's higher, the life expectancy, then you can have a higher target. If it's long, then you have a lower target, and so on and so forth. So Paul Chandler said it best, and said it very, very long time ago, more than half a century ago. Eyes with advanced damage require a pressure below the average. Eyes with limited cupping, confined to one pole of the disc, appear to withstand pressure better, and eyes with a normal disc appear to withstand pressure well over many, many years. So we know which are the ones we need to really, really be worried about. So the treatments for open angle glaucoma, in just one slide, they focus on reducing intraocular pressure. You have eye drops, you have laser trabeculoplasty, and you have incisional surgeries. PG analogs easily the first choice, followed by timolol, followed by oral and topical carbonic anhydrase inhibitors, and alpha adrenergic, 3 or 4 depending on your choice. SLT, very useful for POAG. We do use it as a first line of treatment if it's available. It reduces dependency on drops. And incisional surgery is, trabeculectomy is the workhorse. We'll see a few clips of that, and aqueous drainage device surgery, of course, if it's not possible. Newer procedures, in our setting, frankly, that's the general idea, that they're expensive. The cost-benefit ratio is not enough. So they only work, remember, for moderate glaucomas where the target is mid or higher teens. So for that, and usually most of the NPGS and newer glaucoma surgeries, the IOP lowering is equivalent to 1 drop of prostaglandin. So that's important to understand and remember. So what are the medical interventions? There's strong evidence, 50 trials, and this is a summary, a meta-analysis, that as single agents, prostaglandin analogs are the most effective. We know that. They appear to be similar in their ability to lower, so neither one is similar to the other. And prostaglandin analogs lower IOP more than other agents, including brimonidine. And in this meta-analysis, the mean difference was 1.64, dorzolamide 2.64, and timolol was 5% greater at 6 months. So in combination, dorzolamide and timolol lowers the IOP to approximately the same amount as a prostaglandin. And I think both of them cost approximately the same as well. So the difference is that the prostaglandins have better ocular tolerability, so maybe we could look at that. The surgical interventions, the laser trabeculoplasty, trabeculectomy, And intraoperative MMC enhances IOP reduction, and that's the usual workhorse that we use. So I'll just go through a few short clips. So we've started doing for a long time now a clear corneal traction suture. So this helps in exposure, and the conjunctival flap of choice is a fornix-based flap now from the limbus base that we used to do, simply because there's less dissection required, and we don't need so much of cautery and so much of dissection as possible. So this incision is given just at the area where we plan to make our scleral flap, and thus far, and that's all. So the conjunctival dissection required is much less. So once we have a conjunctival flap, it's a good idea to just push the tenons away rather than cut it. And then the next will show a very light bipolar cautery. Even a heat cautery would do well, but a heat cautery tends to coagulate the sclera a little more. So we tend to prefer the bipolar. And it's very light, so we only cauterize the blood vessels. And if you notice, the incision is given from a little beyond the limbus. So the idea is not to go up to the cornea, because it's now understood that there are limbal stem cells there. And the cause of the very, very cystic blebs that we would see was because the incision used to go right up to the cornea. So now it's understood that you only need to go into the cornea in the center. So here you can see the clear corneal is only in the center, but the sides are spared. So we don't do that. So once the scleral flap is made, we use mitomycin C in most of our surgeries. What you just saw was a scraping of the epithelial cells at the limbus. It helps the conjunctiva stick better. So we tend to do that as well. This is the paracentesis. I've always taught my residents that the difference between a cataract and a glaucoma paracentesis is the direction. We always go parallel to the limbus, especially in phakic people, so that there is no chance of touching the lens. And we do like to inject pilocarpine before entering, so that inadvertently we don't injure the iris in case the pupil is dilated. And once it is gone in, then we make this incision with, this is a 15 number blade, but you can use anything. And then we use a Kelly sponge, but a scissors works just as much. And this Kelly sponge that we have is about 1.75 millimeters. So we usually use about 2 punches, and there's the PI. And once that is done, the standard for trabeculectomy now is to give very tight suturing so that there's no hypotony. But because the suturing is tight, we also use releasable sutures. So usually this is, it's completely the surgeon's choice. Some give the releasable at the apex and say that the posterior filtration is better, but it makes it a little tricky to have a releasable there and then put the side suture. So I usually use 2 side sutures and a releasable on one side, but you can have 2 releasables if you want. The choice is completely yours. So the releasable suture, the principle is that you must have a loop on the cornea to be able to pull out the suture in the post-operative period. This is what works for me. It's called the shoelace releasable suture. So just 4 throws, and then the needle goes into the clear cornea and forms a loop on the surface so that it's easy to pull out at the slit lamp. But you can start from the cornea and do the shoelace later. So that's completely surgeon's preference. So here we make a loop of the suture and cut it flush. So once it's cut flush, then the next thing, of course, is to, while hydrating it, we also at the same time watch for flow. And I like to have very minimal flow at that time. And if it's not, I have a releasable so I can loosen it a little bit. But as you saw, that there was hardly any flow there, which is good. And it's a good idea to have the chamber formed at all times. Do not have hypotony anytime during surgery. So there is no harm in using a little bit of viscoelastic. Conjunctival closure, again, a personal preference. I like 2 tight sutures on either side. And because we had made this area a little fresh, deepithelized, the conjunctiva sticks very well. For me, in my hands, when I do a continuous at the fornix-based flap, then each bite of the suture seemed to leave little buttonholes, and they tended to leak. So I like to have just two, one through the episclera and tightly through the conjunctiva, and have it about a millimeter or so overriding the cornea, because invariably the fornix-based flaps tend to retract a little bit. So even if they retract after 2 or 3 weeks, they come and lie exactly on the um, limbus as you would like it to be. So this has overridden a little too much, and I think I would normally cut it. I don't remember whether I did when I was yes, I would. So I would usually just snip out a little bit, but just a tiny frill which is snip. But this is just about a millimeter or so overriding, and you can see it's absolutely tight. And this is the standard which I use, but the principle of trabeculectomy remains the same. Now, medical versus surgical, the incision surgery lowers IOP more than laser or medication. There's no doubt about that. But initial treatment with lasers tends to reduce the need for medications to achieve the same IOP. So that's one caveat, that if you do a laser first, then the medications required are less. Coming to angle closure glaucoma, remember it's not a single disease, it's a spectrum. So that's PSCS, PSC, PSCG. There's enough literature on how you differentiate each. The mainstay is laser peripheral iridotomy throughout the spectrum. So no matter what, except for PSCS, where you don't need to laser all of them, but PSC and PSCG, the mainstay is first remove the pupillary block. And once it is relieved, then the principles of treatment are the same as for open angle glaucoma. The indications are all PSCGs. PSCG would mean a closed angle and disc and field changes. A PSC, which is synechial or appositional with raised IOP, and a PSCS, in our practice at least, is selective. So you could have a fellow eye of acute angle closure glaucoma in the fellow eye, a family history of angle closure glaucoma, the need for repeated dilated examinations. For instance, if somebody is a diabetic, and you know that the retina clinic is going to keep dilating them. So there, and if the patient is one-eyed, and I put this right at the end, poor access to regular ophthalmic care, because this is not very scientific, but you might tell yourself that somebody is not going to come back and you feel safer if I just do the LI and let them go. So just to complete it, these are eyes in which, sick eyes in which you require glaucoma drainage devices. We have two of them, the model FP7 of the AGV, and this is the ADI, which is now available, which is analogous to the Barwelt, and it's non-valved. All GDDs have the same principle. There's a plate, there's a tube, so you make a conjunctival pocket, you insert the plate in there, you cut the tube and you insert this into the aqueous. So it's a conduit for the aqueous to go out through scarred conjunctiva, or maybe with multiple surgeries, you think you can't do a trap, and that's where we do the AGV. So this poster, I thought it would be interesting to, and I would encourage everybody to, I can send this across. This is something which the Task Force Glaucoma, so you must know that the National Program of Control of Blindness, glaucoma was included just about 3 years ago, which is weird because, I mean, it's such a blinding disease, but we didn't have glaucoma as part of the NPCB. And we thank Dr. Pramila Sharma, actually was Pramila Gupta was, when she was DG ophthalmic, Dr. Ramanjit and all of us managed to convince her that, look, you can't have a national blindness control program and not have glaucoma as part of it. So there was a task force of glaucoma made, and we made this poster, and we'll go through this because the idea is to have this printed on a slit lamp near every ophthalmologist and just read it, because it in a nutshell summarizes how to not miss glaucoma, the blinding glaucoma. So we'll just go through this. This is, I think, available on the National Health and Family Welfare website as well. So this is what it's called. It's an information sheet on glaucoma management. 1 out of 20 people over 40 years is likely to be a glaucoma suspect or have glaucoma. So that's large for a country like ours. 1 out of 20 people over 40. So when would you think of glaucoma? One is when the patient comes, you shine this torch. You see this shadow. Ideally or normally, this torchlight should illuminate the entire eye. If there is a nasal shadow, then you suspect it on the basis of a shallow AC or iris changes. And the next thing is a Van Herix. If the iris is very, very close to the cornea, be very suspicious. So on cursory examination, a shallow AC, and of course, no examination is complete without a disc. So if you have a cupping more than 0.7 or asymmetry more than 0.2 or any notch. So the first thing to do is suspect that there might be either a PACG or a POAG in this patient. The next thing would be tonometry. It says repeat at least 3 times, but at least one Goldman applanation tonometry plus gonioscopy. So if you have a 14 to 18 millimeters pressure and open angles, then it's a POAG suspect. If you have narrow angles, it's PACS or PAC, because normally PACG would not be at 14 to 18 pressures. So you do a tonometry and then do a gonioscopy, open angle or angle closure. The other, if it's higher, 18 to 20 or even more than that, narrow angles and peripheral anterior synechiae and a field defect, usually it's PACG. This is what a post-LI PACG would look like. Open angles and a field defect, you know you're looking at POAG. So just in a nutshell, you would know that you are dealing with a glaucoma. All of these would require both eyes YAG PI, and optic nerve changes and perimetry are required to determine the final diagnosis as to what the stage of glaucoma is and what the target IOP was. So what next? The next thing to do is medications, as we've already said, based on initial highest baseline IOP. So if it's less than 25 mm, one prostaglandin is enough. Switch to 1 or 2 drugs if there are no response, but look for at least 15% reduction. So if the pressures are about 40, look for at least a pressure which has come down to at least 22. If not, then look for something else. 25 to 30, you would require prostaglandins and beta blocker. Watch for 10 days and then add the drug. The idea is not to start with every glaucoma drug, which is what we see on many prescriptions at the same time. 30 pressures in a primary glaucoma is been there for the last 10 years probably. Another 10 days or 6 weeks or 4 weeks is not going to make him blind, but it will give you enough information that is the prostaglandin that I've given working? Is the patient compliant with it? What is the next thing that I could do? So that's why we put just add one and then add 1 or 2 drugs if required and look for a decreased pressure and look if they've reached target. However, if it's more than 30, then you're a little concerned, not so much because the glaucoma is going to progress, but because the diastolic venous pressure of the eye is 30 millimeters of mercury. And if you allow pressures of more than 30 to be there for too long, there is a risk of CRVO as well. So if the pressures go beyond 30, and that was the magic figure for all trials, OHTS or any trial, anything more than 30, they call it an exclusion because you can't put it in a trial then. Then, of course, again, prostaglandins and beta blockers, but usually we do give Diamox as well to give this time to act. Add brimonidine or carbonic anhydrase inhibitors, look for reduced IOP, and decide on a target whether requiring surgery or not. So we've just gone through what IOP is adequate, just to go over these are the discs and corresponding fields. So this is what early glaucoma looks like, a moderate defect and a severe defect because it's right in the center. So 15 to 17 here, 12 to 15 for moderate and 10 to 12 for severe defect. So this is what intraocular pressures would be. Now you need to review and revise it, increase or decrease depending on the stability of the disease. If the target is not achieved or there's progression or you think the socioeconomic status is not going to allow him to continue drugs, consider trabeculectomy or consider a referral. So we've put that in, that it's okay even if you've thought of trabeculectomy and it's not possible for some reason to be done, please refer. And these are the surgical steps that we've just seen. I can't not bring in my babies. So childhood glaucoma is also quite an important thing to know and to look for. These are snapshots from our clinic. Once we are friends with them, they let us do anything. So it's not true that children won't sit at the slit lamp or children won't let you examine. They let you do whatever, as long as you're friends with them. Timely management, these are long-term follow-ups of some of our children. They've grown up, so they come as small babies. They grow up to go to school and become angry. This girl is almost in the 8th or 9th probably this time. And they come back and show you stuff that they're doing at school. So it's very, very encouraging and nice. So to just summarize, what are we to do? It's desirable to detect cases at a stage where optic neuropathy is yet to develop, and there's reasonable certainty that treating the patient will help prevent glaucoma. But that's utopian. There's no way that anybody is going to know that for certain. But what is doable is to diagnose established glaucoma at a stage where treatment can prevent blindness in that patient's lifetime. A comprehensive eye exam is our cornerstone to achieve this, and rational treatment, depending on the type and severity of glaucoma, is likely to preserve this visual function. So thank you very much for the opportunity again. Thank you.
Thank you very much, Dr. Sushmita, for excellent presentation.
Thank
Actually,
you.
this is what I wanted for the ophthalmologist of the state. To be there, very, very basic thing, everything about narrow angle, opal angle, even childhood glaucoma that you have covered well. The most important point probably you have conveyed, and I usually tend to convey, was that glaucoma is accelerated loss of ganglion cell with the aging, which we are trying to delay. Actually, we cannot reverse this aging process.
Correct.
And for that, one more important point that you highlighted is, do not generalize the treatment and do not go aggressively after pressure. That is what we tend to do. The example that you put was of the 85-year-old man with 0.7 cupping and with the life expectancy of 15 years. Do not go after his pressure that lower it by 2 drugs to the level if he is around 22 to bring it to 10. Rather, the lots of drug will definitely cause lots of damage too, as we know all the side effects. This is one message I think that you would stressed time and again. So thank you very much. I'll now invite Dr. Rajiv Tulli for this panel. Dr. Vinod Sharma has not been able to join, probably due to some connectivity problem. So if Dr. Tulli is there, so he can put his comment for the audience. The next question will follow subsequently. Dr. Tulli, please.
Dr. Sushmita, it was a very nice presentation. I think
you.
you have given in a nutshell everything which an ophthalmologist in our state needs. It was really very nice hearing you.
Thank you.
I would like to ask one thing. You said most of the cases you would use mitomycin C. In which cases you will not use?
All right, nice, good question. We would avoid it in very high myopes. I'd be a little wary about that. But I think, and in very elderly patients with primary glaucomas. So the caveat when we were doing our PG used to be, you would use mitomycin in anybody less than 40 and any secondary glaucomas. So a primary glaucoma in a patient more than 40 usually would not. But then it's been a long, long time since then. And now I think that 40 has shifted to 60 probably. So if you have a primary glaucoma in an elderly patient, I would avoid it because the conjunctiva is thin and we don't expect that sort of intense fibrotic response. But I think short of the high myopes, the scleral thinning and the elderly patient, nowadays we use MMC across the board. What we do is titrate the dose and the duration. So we've seen that 0.04 actually works very well. They have better blebs, especially for the young. So our usual is 0.02% for 2 minutes. That's the standard MMC application. But in certain cases, if they're very young, JOAGs, I want lower pressures, NVGs, I tend to use 0.04 for 2 minutes and they do well.
Many of time we have patients who are coming from rural areas, far-flung areas, see the primary disease, and we know they are not going to come for follow-up.
Yes.
How would you feel that we go ahead with the primary trabeculectomy in those patients? And
they would do much better. The primary trabeculectomies would do much better. So our threshold used to be 4 drugs in 3 bottles. And if it's not controlled with that, we used to go in. Now it's come down to, I think, the fourth drug. So most people with one prostaglandin and maybe a combination, one more. So as long as you've reached 3 drops, one prostaglandin and say a dorzoxy or say a combigan, but the minute you think that these three are not enough, so our threshold has gone to the fourth drug, and that because we understand that the longer they're going to be on drugs and the more drugs, the trabeculectomy is not going to work. But if, as you say, they're coming from very far, a primary trabeculectomy would work. But the problem with that, and we always emphasize that, is then they think ki surgery ho gaya. And trabeculectomy will not work if you don't nurture that bleb.
True.
So the problem of doing a primary trabeculectomy in somebody who is not going to come back to you is even worse. Because he's going to think that the surgery is done. He's going to think that now I'm fine. And if we are not going to monitor that bleb and monitor that glaucoma, we are just hoping for luck. And in at least our experience, luck doesn't work in trabeculectomy. The first 6 weeks is crucial if we don't manipulate and manage that bleb. And I'd like to share that I think from Moorfields, there was a very nice review of 119 trabeculectomies, and 75% of them required some manipulation within the 6 weeks, whether it is a massage, whether it is a 5-FU injection, whether it is needling, but only 1/4 in probably the finest eye hospitals in the world could salvage a trabeculectomy if they did not touch it. So I wouldn't want to send out a message that if you have somebody in the rural area who will not come back to you, do a trabeculectomy, because that's doing more harm. Safed motia is fine. The operation ho gaya, motia is cured. But educating a rural person that kala motia is not going to be cured, you have to keep coming back. I have to keep monitoring you, and it is not. So that's
True,
the
true.
only caveat.
See,
So
yes,
that's our
very
take
true.
on
Right.
it.
Only thing is with the trabeculectomy, you may shorten the follow-up period. You may not say first few
Yes,
months,
true.
and you are sure that the trabeculectomy is working, and you have assured maybe one
Yeah,
drug or so
yeah.
is required. Then
True.
it's
Then
good.
it's okay. Good.
Otherwise, we can't send it that
Yeah,
you
you
go and
can't say
once.
that you, and
That's
that's the thing, that motia for them is the same thing, and the patient might think ki acha theek hai, kala motia ka operation ho gaya, I'm fine. So that's if we can ensure, and it really breaks our heart with children, because you've done the surgery, you've told them, and then 5 years later they're back with a blind child. And
true.
how I get after them, I tell them, you should, it's criminal that you wait so long and then you come back, but that's what they think. So that's what happens. But anyway, it's a tough game either way, actually.
I-
Both sides. And plus, of course, the risk of infections, the risk
Okay.
of complications in trab if we let them go.
Yes. Dr. Sushmita, I have another situation which we commonly see in peripheral institutes. We have some of the people with unilateral advanced glaucoma or the loss of, say, absolute glaucoma in one eye, while the other eye is nearly normal, without any cupping, without any. Many times these people are put on treatment, and you might have seen these tricky situations. Everything is normal. Sometimes with pseudo exfoliation or without it. How to go in such cases with unilateral advanced glaucoma or unilateral loss of eye with no evident changes in other eye?
Oh, very unusual. I would be very wary of looking for secondary causes. It's asymmetrical, but having absolutely advanced glaucoma in one eye and normal other eye is very unusual. So, and the thing is of maybe we have to really ask them, some desi dawai, some steroid, something they are putting, I don't know. It's very unusual, but we treat it as it comes. I mean, we search for it.
But
Pseudo exfoliation would be my first bet, that pseudo exfoliation can cause this sort of situation. But otherwise, if it comes to us and we don't find anything, we just treat it as we would. I mean, treat the advanced glaucoma as an advanced glaucoma and treat the near normal as near normal. But having said that, one interesting thing I can share, an observation that we've
Okay,
seen.
so you
I think
not
we
recommend.
don't recommend what? Sorry. No, I
That
didn't
you
get.
don't
We would
recommend
not.
treatment for so-called normal seeming, normal eye, the other eye which is normal
No,
and
I
one
would.
eye is absolute or advanced glaucoma, whether to go for drug both eye or not.
No. If the normal eye has normal pressure, maybe look, the first thing is angles. PACG is notorious for being asymmetric. So maybe the other eye is just
Okay.
PAC and then we do the laser. And if we are very sure that it's POAG only, maybe I would do a diurnal variation at the most. Maybe we are missing a spike, which we are not seeing. But if on the diurnal or the day diurnal also, it's okay. I would tell the patient that.
How
Yeah.
you find diurnal variation? We usually do not do. Do you diagnose really lots of people with it, or it is hardly of any relevance as far as I have observed?
No, it is when
Diurnal variation.
if I see a spike at hours which is beyond the clinic hours, then I tell them that look, तुम्हारा शाम को 7 बजे pressure बढ़ रहा है, तो I would treat that. I would treat the highest IOP on a diurnal, and that in that way it is not so much maybe for diagnosis, but for making management decisions. Sometimes there's a lot of fluctuation. So then I know that, that on one time the pressure is 21, the other time the pressure is 12. So I'd be very worried in a patient like that. So they are the dilemmas. NTGs, all of them undergo diurnals, but the situation that you've said, that's so-called normal. So maybe we are just missing it, and that particular patient I would treat. So I would take each eye on its own merit and then go ahead with treatment. Yeah. So I was just going to share that we've also seen that if you have advanced glaucoma in one eye and not so advanced or maybe early glaucoma in the other, when you do surgery on one eye, the IOP of the other eye tends to shoot up post-operatively. So the idea is because that there is a central mechanism for aqueous production. And when the high pressure eye becomes low, the reflex is to secrete more aqueous to maintain the homeostasis. And if the other eye is glaucomatous with a compromised outflow, that increased aqueous rises it. So when we do a TRAB, we are very wary of these so-called other eyes which are normal, because that's when it comes up, that's what has happened. So that's another small thing that I thought I'd share.
Oh, yeah. That could be a big explanation for what I had stated. Yeah. Okay, if you have any question from Dr. Jitendra Rudki is there on the line. We have some question from the audience. Whether Dr. Rudki has recorded it, we can put it to Dr. Sushmita. Dr. Jitendra, are you there? Or he has lost the connection? Dr. Soni, any question from you, please?
Dr. Saab is muted.
Otherwise, I invite Dr. Tulli to put some.
Please unmute yourself. Dr. Rudki, please unmute. The question is NVG glaucoma with the PL positive. What we can, how we can manage these patients?
NVG glaucoma with PL positive. This unfortunately not much we can do. I mean, we've lost the battle there, frankly. If the pressures are very high, I can share with you. At the most, we would do a cyclophotocoagulation with diode. But if we've already gone to a PL plus NVG, then there's very less that we can, do. But we have to get the eye to be comfortable.
Are there more questions, Dr. Rudki, from any audience? You can put it. Otherwise, we are nearly at the end of this session. Before Dr.
We end this. All the questions, but there is no more questions in our group also, and also in the chat. This was a question. Okay. I will put in the writing also. You continue your talk, please. I'll put in the chat.
Dr. Tulli, any more comment, please, for Dr. Sushmita or for glaucoma?
Dr. Sushmita, We observe a lot of cases of pseudoexfoliation, and what I have observed, they behave much worse as compared to primary open angle glaucoma.
Correct.
And
Correct.
you see, many times what we have observed is one eye blind and other eye advanced. And but fortunately, many of those people, we have done trabeculectomy, and it has been a success. Most often we succeed in lowering the intraocular pressure with trabeculectomy in these patients. Your observation of this?
Yes, pseudoexfoliation is a very known risk factor for both progression, rapid progression. So when we see pseudoexfoliation, we're very scared. If you have pseudoexfoliation with glaucoma, then our antennae are absolutely raised. And the other thing that we have observed is even if they have early cataract, if we do the cataract surgery along with the glaucoma, so we tend to do a lot of phacotrabs with them, because apparently there is some anecdotal evidence that if you do the phaco, the IA and the energy of the phaco itself washes out a lot of pseudoexfoliative material from the angles, whatever it is there. And there are some who go so far as to use a silicone tip cannula and do a sort of vacuum of the trabecular meshwork also, which we don't sort of recommend that because it might cause a lot of trabecular damage. But just doing the phaco and taking that out many times is, so many times we might not do the trab also. If you have a lens there and if you have a moderate glaucoma, we just try a phaco, an early cataract surgery first. And we've realized that just washing out all that stuff from there, maybe after that we can manage them on 1 or 2 drugs maybe. But you're right, pseudoexfoliation is a problem, and for some reason all the hilly states seem to have a lot of them. When we have a Himachali topi sitting outside the room, I impress my students very much by saying, "Yes, pseudoexfoliation," and they say, "How did you know?" I know.
That's
yeah.
Yes, that has been even my observation, that even simple cataract extraction in moderately high pressure with pseudoexfoliation, it relieves many of them from high pressures. Some of them have some field changes or some cupping also. They become almost non-progressive following deepened anterior chamber and the so-called washing of the pseudoexfoliation material. So many phaco surgeons I had seen patient being referred for glaucoma opinion, and they just do their cataract extraction, and it works in good number of these cases. That's what you were probably trying to stress. Dr. Sushmita, one more question that you keep on telling is the over treatment of the glaucoma. That we have where patient has one paracentral scotoma. You at say 10 years back, he was diagnosed as glaucoma and put on some travoprost or anything, 1 or 2 drug, and this is non-progressive. The pressures is within 20s and nobody is ready to withdraw this drug if the glaucoma is non-progressive, which is so-called that paracentral scotoma might appear at one point of time. What you have to comment? You have commented in one of the conference on such thing that we sometime overtreat glaucoma before we end this session.
Underdiagnosed and overtreated. That is our problem.
Yes.
All of us seem to say that the glaucoma is underdiagnosed but overtreated. Jab dikh jata hai, then everybody goes whole hog. Not so much for open angles, but what I've seen a lot of overtreatment is post-LI. You know, you suppose a patient comes with PAC or something with 26 pressures. You put them on a beta blocker because you plan a laser iridotomy. You do the iridotomy. And then that beta blocker continues forever and ever. Then you have to take it off and see, what is happening. So that's one. And regarding the other one, even if the pressures are within 20s, I would think that maybe the glaucoma has not progressed because the pressure is within the 20s with the drug. So it will be very difficult to, I didn't get that question. If the pressure was 26 and then you put a drug, and that paracentral scotoma does not progress because you have made it 21 from 26. So in that situation, I don't think we should take the drug off because he has not progressed because of the drug. Probably if we take it off, he might.
Okay, 20 doesn't mean, less than 20 or around say 15 to 20. These are the situations actually which are being overtreated, not beyond 20 actually, less than 20 or more than say 16, 15.
Yes, absolutely. And not just
Non-progressive,
that, you have
actually repeated field year after year normal.
No, at 24 pressures, they are on one prostaglandin, a combination alpha-GAN, something, something. So sometimes, you know, you have a notes in the clinic saying, why is this patient on 5 drugs? Then we start taking them off. So some of my happiest patients are those who have said you don't have glaucoma and I've taken them off drugs. But yes, we do a lot of taking
many
off.
times I have done
a lot of taking off.
Many of such patients I have also and put them on regular follow-up of visual field as well as pressure. Usually they do not cross 20 or 22. Then let's keep them if they can follow it up with visual field and pressure. At least put them off drug for some time. If they maintain that same pressure, then it may not be. The another converse situation is the pressure.
I also want to reiterate. No, sorry. I also want to reiterate no treatment on NCT. It is the NCT pressure which is a problem. One screening tool, 24 pressure, 3 drugs. Then, you know, that's the other over treatment.
Yes. Yes.
Yeah. Sorry, you were saying something.
Yes. Okay. Similar question is pressure within 14s and 16s or 18, and still patient is progressing with the visual field losses. These are the another situation where how drug works in this situation.
Yes.
So I think they are the more important, where the calibration or the prostaglandins or higher drugs are needed probably.
Yeah, true. True, because if they are progressing, then we need to see why they are progressing. I mean, obviously, either the pressure is not low enough, or there is a spike. So somebody who is progressing on 14 is another situation where I would like a diurnal, right? Why should he be progressing at 14? Maybe I'm missing a 20 spike. So then I know that it needs to be low.
Rather, it is the late or even one spike in 24 hours that damages more than the continuous raised intraocular pressure, rather the night spikes or the diurnal spikes. So if there is any comment for Dr. Tulli, then we can close it. And we thank you very much, Dr. Sushmita. Dr. Tulli, please.
Dr. Sushmita, most of the general ophthalmologists are putting patients on drugs. And I'd like you to tell them what are the basic medical checkup it should be done before we start medical management, because many of the drugs may have serious side effects. So what would you recommend? Having a look at the pulse, asking for bronchial asthma, this everyone is doing. Anything else you would recommend?
I think with the prostaglandins coming in, that has taken off our anxiety a little more, because prostaglandins usually don't have any serious side effects. So the first one, but of course, before putting timolol, that's the first thing. I think by and large, we just ask them for hypertension and bronchial asthma. Bronchial asthma because you would not like to give timolol, and hypertension because if they're on systemic beta blockers, then your timolol is not going to work too much, not be too effective. But to be frank, Dr. Rajiv, I don't think we do much more than that in our medical practice, unless they come and tell us that something is going wrong. But
I think one thing is in the childhood glaucomas, I'll tell them never use primordial, because many times,
yes, of course,
that I have seen once or twice, because that can be fatal also.
Yeah. And they're very sleepy, and they say very sleepy. Yeah, absolutely. That's true.
It was wonderful listening to you.
Thank you so much.
Okay, Dr. Soni, if there is any comment from you, we really thank Dr. Sushmita for nice, and we'll trouble you more, Dr. Sushmita. If you speak such a beautiful thing at this format, you will be punished for speaking such a well way and such a so good. So because webinar will be a reality of today's situation, so we'll definitely trouble you in between.
My pleasure. No problem.
Once more. So any comments from you, then we can close this. And I also thank the Entod for their support of organizing this webinar. Dr. Soni, please.
I'm here to thank you all, and especially Dr. Sushmita for her elaborative and excellent talk. And she has explained in every aspect that how to treat the patients of glaucoma, how to diagnose, how to treat, and when to say no to the drugs. Thank you very much.
Yes.
Thank you, Dr. Sushmita, and thank you all.
Thank you. Thank you for the opportunity.
With this, we can close this webinar. Thank you all. Good night. Okay.
Thank you.
Good night.
Bye. Good night.
Bye.
Okay,
Bye. Good night.
okay.